Hello friends, welcome back to my channel MedVision. In today's video, we'll be learning about the Klumpke'S paralysis. So let's get started. Klumpke'S paralysis. What exactly is Klumpke'S paralysis? It is a condition which occurs because of the injury in the lower trunk of brachial plexus. To watch my video on brachial plexus, click on to the I button or check out the link provided in the description box. Cause of injury. The cause of injury is undue abduction of the arm. This action of movement is known as the abduction. So, while clutching or grasping, clutching means grasping. So, while clutching something with the hands after a fall from a height or because of the birth injury, we might abduct our arm in an undue manner or in an improper manner, which leads to this paralysis. Nerve roots involved. The C8 nerve and the T1 nerve together forms the lower trunk of the brachial plexus. So the nerves involved are mainly the T1 nerve and partly the C8 nerve. Muscles paralyzed. The lower trunk or the branches of the lower trunk supplies the lower parts of the upper extremities. So the muscles paralyzed includes the intrinsic muscles of the hand, which is supplied by the T1 nerve, and the ulnar flexors of the wrist and the fingers, which is supplied by the C8 nerve. Deformity. The deformity resulting from the Klumpke'S paralysis is known as the claw hand. In the claw hand, there is hyperextension at the metacarpophalangeal joint. As we can see here, there is hyperextension. That means this is very extended at the metacarpophalangeal joint. The metacarpophalangeal joint is the joint present between the metacarpals and the phalanges, whereas we have flexion, as you can see here, flexion at the interphalangeal joint. The interphalangeal joints are the joints present between the phalanges. Disability. The disability which results because of this paralysis is known as the Horner's syndrome. The Horner's syndrome occurs if the T1 vertebra is injured proximal to the white rami communicants to the first thoracic sympathetic ganglion. Now this vertebrae present here is the first thoracic vertebrae, and this is the sympathetic ganglion of the first thoracic vertebra. This is the white rami communicants, and this is the grey rami communicants. So, if T1 is injured proximal to or near to the white rami communicants, then there are chances the person might get the Horner's syndrome. What happens in Horner's syndrome is there is ptosis, which means drooping eyes. There is miosis, which means excessive constriction of the pupil of the eye. There is enhydrosis, which means absence of the sweat glands, and enophthalmos, which means posterior displacement of the eye, and we have the loss of the ciliospinal reflex. The ciliospinal reflex is the pupillary skin reflex. That means if the right side of the neck is subjected to the painful stimulus, the right pupil dilates. The increase in size is typically between the 1 to 2 mm from the baseline. This is how the eye of a person suffering from the Horner syndrome looks like. Various other disabilities include the complete claw hand, the cutaneous changes The cutaneous anesthesia occurs in a narrow zone along the ulnar border of the forearm and the hand. The vasomotor changes. The skin area with the sensory loss is warmer due to the arteriolar dilation. Also, because of the loss of sympathetic activity, the skin area is drier because of the absence of sweating. Trophic changes. Long-standing cases of paralysis leads to dry skin. The nails crack easily with atrophy of the pulp of the fingers. Check out the link in the description box for the notes of this video. Also, if you find this video helpful, please do like, share and subscribe my channel. Also hit the bell icon to never miss the new update.